Hello, everyone. I'm Sancy Leachman, and you can also see Lisa Aspinwall. We are going to be presenting a really great topic for us, sharing genetic test results with people at high risk of melanoma to motivate behavior change. And we'll be talking about, in particular, a trial that we've done called Behavior Risk Information Genealogy and Health Trial, BRIGHT. And so you'll hear both of us talking about that. We're going to try to accomplish two things with this. The first is to tell you about the data and tell you everything that happened, but also to tell you our story, because this has been a sort of a detective hunt all the way along, and it's something that neither one of us could have ever accomplished alone. So at the start of the project, that was all the way back in 2005. So we've been working on this for quite a while. There was a real controversy in the field of melanoma about whether or not genetic testing for melanoma was helpful, and even whether it was ethical to do it, to provide those results, if there wasn't anything that you could do that was actionable about that. And so we go ahead to the next slide. Yeah, and so some of those questions were, don't people already know they're at risk? And shouldn't they already be doing everything they can to prevent cancer or find it in their course? But the thing was, and is it ethical to offer testing when it doesn't change the management in any way? When we can't change their genes. So what are we going to do differently except recommend sun safety and self-exams? But what I was finding in clinic, I found a different story sort of starting to unfold with my patients. And I found out that knowledge really empowered the patients to behave in different ways. And I found that, that patients that seemed to receive these results, they were complying better with my recommendations. And so I started to ask that question, shouldn't we be trying to include the genetic test reporting as part of the clinical care for these patients, because it was enabling them, empowering them in some way. But I had no experience in behavioral work. I was a molecular biologist and a dermatologist. I had no experience, and I needed a partner. And that is where Lisa came in. So Lisa, I'm going to turn it over to you to talk about your experience.
Thanks, Sancy. So I am a social psychologist with a specialty in health psychology, and I study how people think about health risks. And at the time I arrived at the University of Utah and had the good fortune to meet up with Sancy, I was studying health risks, but having to make them up so that I could create experiments where I could vary their severity, their age of onset, their preventability, and other key things to try to understand how people think about health risks. And I was studying these things in people who were not at any special risk, like the people we're going to be telling you about today, but people who are at population risk, not high risk. So most of the challenge for social psychologists and health psychologists is how to get people who don't think they're at risk to appreciate that they are at risk and they need to be taking preventive measures. What we're going to see is that when you look at hereditary cancer risk assessment and genetic counseling, you have a very different situation where you have people who are at very highly elevated risk, but at the same time are perfectly well. They have no symptoms. And so when we're asking people to undertake behaviors for cancer prevention and screening, that's a big ask. If you feel fine, we don't like to do things that are expensive or inconvenient or embarrassing or boring or time consuming. So how do you get people to think about those things? So today we're going to share with you what we've learned in 16 years of asking questions about whether and why adding genetic testing to the more traditional forms of patient education motivates improvements in prevention behavior. We'll turn this back to Sancy.
Yeah, so now it's my turn, because as the clinician of the pair of us, I want to bring everybody up to speed and on the same page with some of the basic information you need to understand about melanoma and our patient population, so that you can see why we designed the study that we did and how it went. So first of all, melanoma, it's really important that you understand melanoma is there's a genetic component and there's an environmental component. And what melanoma is a cancer of those melanocytes. And those melanocytes are present in that basal cell layer. And UV light reaches down through the epidermis and hits those skin cells. And basically, the melanocytes are the cells that make brown pigment. So when you get a tan, the reason you get a tan is because the UV light has come down, caused DNA damage, which signals the cells in the skin to encourage the production of pigment. It's an SOS sign for the melanocyte to save itself and the keratinocytes around it. And so the important thing about that is that everybody as an individual has a lot of different combinations of genes that make this environmental exposure more or less risky for them, right? And so you can see that UV light is one of the things that we want to avoid if you're a high risk patient. So go ahead to the next slide. The other thing that I think everybody in the group hearing this should know is that melanoma is a deadly cancer. Sometimes you hear the comment, well, it's just skin cancer, just cut it out and you'll be fine. But melanoma is in a different class. It really is a deadly cancer, and it's most deadly if it's caught late. So the thing about melanoma is that if you catch it before it's had a chance to spread to other parts of the body, your chance of being alive in 5 years is 98%, but it's a totally different story. If you catch it after it's spread, it's about a 24% chance that you'll be alive in 5 years. So catching it early makes a big difference, and prevention of it happening in the first place has the potential to be, revolutionary for the field. So what are the things that you can do? There's a few things that we recommend all the time in clinic, and that's sunscreen, protective clothing, avoidance of UV light, self-skin exams, and provider skin exams. And this shows, this slide is basically hammering that message home, right? The first picture is a picture of a family that shares a lot of risk factors: red hair, lightly colored skin, blue eyes, freckles, and they share those traits, but those traits are really common throughout the population, and they don't individually or even together, they don't increase your risk by a huge amount, just an amount that would be around a 4-fold higher risk or so. But if you look at the other picture, that's a picture of a pedigree. And in that pedigree, I think you can see that people in that family, those are all family members within a single family that we worked with in Utah. And you can see in the green highlights, those are people who have pancreatic cancer. The red ones are all of the melanomas in the family. And there's one that's a black square that's a melanoma in pancreatic cancer. And what that demonstrates is that this is a heritable thing that is high risk. If you get a mutation in that gene, in this case it was a P16 or CDKN2A gene, if you get a mutation in that gene and you pass that gene on to the next generation, which is a 50% chance, you've only got 2 copies, you pass on the good one or you pass on the bad one. If you pass it on, then they have a very high risk of getting a melanoma. So go to the next slide. So I'm going to ask you guys some questions. What is the percent chance that a person with red hair will get a melanoma in their lifetime? Now you guys think about it, okay? I'm going to ask you one more question. What is the percent chance that a person with a P16 mutation will get a melanoma in their lifetime? 4% on this one. What do you think the next one is? Okay, 76% lifetime risk. So here's another question then. That raises, that comes back to that original question. If they know that risk, aren't they already doing everything they possibly can? So how likely do you think these patients are to follow our recommendations for using sunscreen? And I'm not going to answer this question. Lisa's going to go on here in just a minute to talk about how we get to the answer of this question.
So I want to share with you the results of 2 studies. Here is our first one, and it's going to give the answer to the question that Sancy posed in just a moment. So in our first one, we had the opportunity to provide clinical genetic test results to a sample of 60 people who had participated in prior research, including the gene discovery research that allowed the P16 gene to be identified. What's important here is that 1/3 of these family members had a diagnosis of 1 or more melanomas, often as many as 9. Some people had 3 melanomas, but 2/3 were unaffected, meaning they have no prior diagnosis and no personal history. So why are we focusing on the unaffected people? Well, the idea with precision medicine is that you'll be able to tip people off ahead of time before they develop a disease to know that there are certain things they should be doing in terms of prevention and screening that will improve their health outcomes. Now, what about the proportion of people who practice protection in the sun or photoprotection? In the gray bars are family members from this initial study who've had a diagnosis of melanoma, and in the red bars are members of the same families who test positive for that P16 gene we've been telling you about, but who do not yet have a personal diagnosis of melanoma. And the first thing you'll notice is that the red bars are a lot smaller than the gray bars. And so when we asked you what percent of people use sunscreen, if you're looking at people from these families who have a history of melanoma, that'll be around 55%, but it's only 30% for members of the very same families who have tested, who will be told that they've tested positive. So this is at baseline before they've received any information. And you can see that people are more likely to say they wear protective clothing, long sleeve, broad brim hat, or that they avoid peak exposure and try to stay in the shade. Nobody likes sunscreen, it's sticky and expensive. But the important thing here is that these adherence rates are probably lower than the numbers you were expecting to hear. So does genetic testing provide benefits? So our first study, we provided those clinical genetic test results, and then we followed people another 5 times over the next 2 years. And what we found is those unaffected carriers, test positive but no personal history, report improvements in how thorough their skin self-exams were in terms of the number of body sites they examined, greater adherence to annual total body skin exams with a medical professional, greater reports that sun protection was part of their daily routine, greater use of protective clothing, reduced number of sunburns, and these gains were sustained at a 2-year follow-up. Importantly, the provision of that positive genetic test result did not create increases in anxiety, depression, or worry about cancer, and patients reported multiple benefits, both informational and behavioral. They reported a greater understanding of their risk and greater motivation to practice photoprotection and screening. So far so good. And we were very, very happy and encouraged with these findings. But does genetic testing really provide benefits? So one tricky issue in the study of genetic counseling and test reporting is that you can't provide the genetic test results without the accompanying education. And that asks the question, well, maybe it's the education and counseling about family history and about medical management, prevention, and screening. Maybe you don't need an expensive genetic test, right? Wouldn't it be important to show that there's something about the test that is motivating and informative in a way that the accompanying education of patients without a test isn't? So we set out to design a study to test whether there's an impact of genetic test reporting over and above the receipt of standard recommendations based on family history. So this brings us to the BRIGHT project, that behavior, risk information, genealogy, and health trial that was funded by the National Cancer Institute. All of the study participants are unaffected members of high-risk families, and by high-risk families, we mean families that have at least 3 first or second-degree relatives with confirmed diagnoses of melanoma. Many of these families had many more affected family members. All of our participants are unaffected, so no one in the study that we're about to share with you has a personal diagnosis of melanoma. We're going to come up with a prospective, non-experimental control group. This is a mouthful. This is a simple way of saying it's unethical to randomly assign people to either get or not get genetic test results, or to get positive or negative results. You have to give people their actual test results. But we came up with a meaningful comparison group of members of high-risk families who have the same rates of melanoma and merit the same management recommendations, but they don't carry the P16 gene, and no one knows what it is that they do carry. So we're not withholding a test from these folks. They're not eligible for P16 testing because their families don't carry a P16 mutation. And I'll say more about this in a moment. So we're not randomly assigning people to results. We're taking advantage of a natural experiment that involves 2 different kinds of families. We're going to provide individualized cancer risk assessment for each patient with or without genetic testing. So the no test controls that we'll be talking about receive counseling based on family history alone, but no test result. We're going to compare them to people who get that test result. Okay, so here's a schematic to try to help us share with you the logic behind having these 3 groups of participants. So We're going to start with P16 families. They are the people for whom genetic testing is available. So you take the test after education and informed consent. If you are positive, you're going to show up in the slides that we're about to share with you in red. Your risk that you are counseled to have is 70 times population risk, or up to 76% for US residents. If you test negative, you will be in black. Your counseled risk is twice population risk. So notice that the presence of the test affords, for members of the same family, there's a huge difference now in what we can tell people about their risk. It's either 70 times or it's twice population risk. Now, if people are in what we'll call a non-P16 family, these are the families that have been found through prior testing of their more senior relatives not to carry this mutation. Genetic testing for P16 makes no sense for them. They're not eligible. There are no test controls. They're going to show up in blue. What risk estimates do they get? 30 to 70 times population risk. So you're told this almost the same risk information as our P16 positive carriers, but we can't be more precise because there's no gene to test for. Okay. And as I mentioned, we have assessments at baseline, post-counseling, 1 month, and 1 year. Okay, I'm going to do something unusual in talk. I'm going to show you the one slide where there's no differences across the group. So what I'm talking about is questions that we asked people from baseline, post-counseling, 1 month, and 1 year. How much do you understand about melanoma itself? Something called illness coherence. And what you can see is kind of a phenomenon where education lifts all boats. All 3 groups of patients report a better understanding of melanoma following the individualized counseling they received. Here's where things start to get different. If instead of asking how much do you understand about melanoma, you ask how much do you understand about your risk? What does it mean? How did you come to have this risk? Here's where we're going to see the P16 groups, those in the red line and the black line, taking off and being very different from the blue line, even though people got exactly the same education and counseling. The only thing that's different between these sets of families is whether you are eligible to get a test result. So what you can see here is that people who got a genetic test result reported a greater understanding of what their risk meant and how they came to have it. If we look at comparative lifetime risk compared to other people, your age, gender, and skin color, what's the likelihood you'll develop melanoma in your lifetime? You can start to see a huge difference between the red line and the blue line. So in the red line are our carriers with their positive test results. They come into the study thinking they're somewhat above average in risk. They get that positive test result. This goes to the right answer, which is much above average because they are 70 times population risk. But look at the blue line. Their risk perceptions are unchanged. And we see this on other ways of asking people about perceived risk. They're saying somewhat above average. The right answer for them really should be much above average because they're 30 to 70 times population risk. And then in the black line, we see that the non-carriers report that their risk is still above average, but it goes down from what they thought at baseline. And that is accurate and appropriate on their part. What about other ways of thinking about risk, like the urgency and priority? Is dealing with your risk of getting melanoma a priority? So everyone in these families knows that they have this risk, but how much is it something that people feel they need to take action on? Here is where we also see a significant increase in people who test positive, shown in the red line. So compared to their baseline, they already believe it's a priority, but this moves them up closer toward that strongly agree. And those differences are maintained 1 year later. The reason that I want to emphasize this slide is notice the blue line, we don't see any change in prioritization of risk. These are all patients who have had a half-hour-long individualized cancer risk assessment with a genetic counselor, received a research-based, extremely thorough total body skin exam and detailed education about what to do. Their priority is good, it's at 4 out of 5, but it does not increase as a result of receiving this risk education. It does increase if you got the risk education plus that genetic test result. Notice that it doesn't go down among those non-carriers in the black line. Another reason I want to emphasize this is that this priority of risk measure is a very successful predictor of who is going to increase their sun protection behavior up to 1 year later. So prioritization of risk is a massive predictor of improving your behavior following genetic counseling and test reporting. We see a similar pattern when we look at motivation to reduce sun exposure, perhaps the most important measure that we have. That is higher both 1 month and 1 year later among those carriers who got that positive test result than among the no test controls who were told they were 30 to 70 times population risk. Okay. Now I'd like to share with you two of our kind of cooler measures. This project was a lot of fun to be involved in and work with photobiologists and engineers. Everyone was equipped with a dosimeter that looked like what was a watch band with maybe half of a marshmallow on it. If you cut a marshmallow in half and stuck it on there, it was a white disc. It didn't show patients any information, and it was recording their UVR dose in 10-second intervals every day for 27 days, for 3 sets of 27 days. So patients were very generous about wearing these things for as often as they did. And so this is going to compute what's called a standard erythemal dose, which corresponds to how much it takes to produce a slight reddening of the skin as you would get in a mild sunburn or being on your way to a mild sunburn. Okay. The reason that we're interested in this is that it's an objective measure. It's very hard to remember how much sun you've gotten, let's say, over a year. I don't know how many of us, well, maybe with the pandemic, if you were working inside, it would be an easy answer, no sun. But for most of us, that would be a really difficult question to answer. But with these dosimeters, we can actually see how much UVA and UVB people have been getting in those 27-day windows. And what you can see in the red line here is that carriers show a unique decline in their average daily UVR dose that's being received by the dosimeter on their wrist 1 month after counseling, and that both carriers and controls at 1 year show a significant decrease in average daily UVR exposure. So both groups are doing a better job of staying out of the sun. There's no change in the non-carriers, but it's the carriers who show a more rapid drop up 1 month after counseling, and importantly, that is sustained 1 year later. Very important for behavior change to look and see how long it lasts. Okay, our next cool thing that we did was to use a laser-based measurement to assess skin color at typically exposed sites. So the sites that we'll be talking about are the dorsal wrist, the outside surface of your wrist, and sites right at the face. The reason we're interested in this is that the dosimeter measures how much sun the dosimeter got. But if people are wearing long sleeves or wearing sunscreen, they are protecting themselves against the sun. So where the rubber hits the road is how tan were people? How much change was there in the color of their skin at typically exposed sites like the wrist and face compared to those that are not typically exposed, like the inside of your upper arm or just below your waistband. But here's what we find. If you look first at the wrist, you can see that the red line uniquely shows a decrease in how objectively tan those carriers are after receiving a positive melanoma genetic test result 1 year later. We do not see this in the other two groups. In terms of melanin index scores at the face, there were no differences and no decreases in the groups. If you look at the two graphs, you can see that a higher number means more tan. People were less tan on their faces. We suspect that's because people take better care of the skin on their face, often through the use of cosmetics that contain at least some sunscreen. Okay, so where does this bring us in terms of understanding the impact of genetic testing on how people might manage their familial cancer risk? So what we're looking at is how genetic testing has the potential to increase people's understanding of their cancer risk and their prioritization of its management. And what we were not able to show you in slides today is the provision of that genetic test also increases people's sense that those management recommendations that their doctors are offering to them apply more to them. And as we've seen, they also increase people's motivation to perform them. What this does is it brings us one step closer to the goal of understanding how genetic testing can promote both personalized medicine and, as well, Sancy will explain, personalized prevention. Please take it away, Sancy.
Thanks, Lisa. So I think everybody in this group, I don't have to sell you on prevention. You know that an ounce of prevention is infinitely better than treatment for something, for a cancer. That's that's the way we all feel. And what we've shown, what I'm excited about, is two different things. The first is that if we want prevention to take hold in our society as a major way of preventing, of really dealing with cancer, we have to tackle the behavior problem. And this is broader than just behavior for melanoma. What this is telling us is about how you get to people, how you help them to help themselves. And that's really what this is about. And so it's much broader than, it's in the whole field of medicine, how you do this, not just this. The second thing that I'm excited about is that this is about, if you think about the progress of medicine over the last decade, where we've been moving is toward precision medicine, where we actually apply a precise medicine or a precise tool to the disease that we're treating. And now what this is talking about is being able to apply precision prevention.